if we could all take our seats. We have the excellent time for dancing. Welcome everyone, thank you for coming out. I know it's raining. We have our first visiting speaker who I will introduce in a moment, but I have a few announcements. And the first one is the ophthalmology match result came out Tuesday. And as you know, there are 50 students per class at Dell Med, and our oldest class is in their 4th year. So these of the 50 students, there were 3 that were interested in ophthalmology. They spent significant time with 2 of our awesome affiliate faculty, Shelley Day and Bob Wong, doing their 9-month research block. So we have 3 students that all matched in ophthalmology. Kevin Elwood, who is here. Kevin, give us a wave. Matched at the University of Wisconsin-Madison. Pooja Parikh, who's with us as well, UT Southwestern, and Saba Akfani, University of Southern Florida. And that was with the help and have done work with the TOC folks. So many congrats. Hopefully many more to come. And then we have a development update. We have Randy Mejia here. She's our development officer. There's Randy right here. Hi, Randy. Exciting news, a development update. And it is to announce tonight, it's my great pleasure to announce the Dr. John and Miss Suzanne Shore Distinguished Lectureship for Excellence in Ophthalmology. John has given a large gift to establish and endow this lectureship that will begin in 2020. And this is what the gift will do, what this lectureship will do. The gift will establish the Mitchel and Shannon Wong Eye Institute. And here's John right here. Establish our Eye Institute as, at the national level. It'll demonstrate to the community our commitment to excellence in education, research, and patient care. And we will invite nationally recognized speakers, much like John himself, who will deliver cutting-edge CME-bearing content to Central Texas ophthalmologists. So bringing high-quality education to Central Texas in ophthalmology. So thank you, John, very much. We very much appreciate it. And now, to present my former resident, Andy Lee, as our first visiting professor. Super excited to have you, Andy, and I'm going to do a little summary here. Andy went to the University of Virginia for undergrad and got his MD there. And then he was a resident at Baylor College of Medicine. In 1991, it was my first year as faculty, so Andy was my second year resident on pediatric ophthalmology, possibly why Andy did not go into after his residency, Wilbur Eye Institute, and neuro-ophthalmology with Neil Miller, and his co-fellow was Dr. Elliot Broman, who is here in the audience and one of our esteemed faculty members. He did Neuro-Path fellowship as well, came back to Baylor as a neuro-ophthalmologist from assistant to associate professor in that time frame. Then in 2000, headed to the University of Iowa, where he was rapidly promoted again and became chief of that service. And then since 2009, he's been chair of the Department of Ophthalmology at Methodist Hospital with appointments at MD Anderson, Baylor, and many other hospitals outside of Houston. And what his service has been, and academic roles. For the Academy, he has served on a jillion committees and leadership positions. He got the Senior Honor Award like when he was a baby. In North American Neuro-Ophthalmology Society, he's past president, and he had his meeting in Hawaii, which I think indicates he has a lot of sway with the program committee. And in terms of the ACGME Milestones Project, Andy has been at the core, incredibly instrumental in developing milestones for ophthalmology. And as John Shore well knows, who's my associate program director, these milestones are guide resident education. Andy is a premier educator. He's published over 400 peer-reviewed papers, 40 book chapters, 8 full textbooks, over 300 speaking invitations, 14 named lectureships, and 7 resident teaching awards, which is a testament to his incredible ability as an educator. Andy, it is my great pleasure to have you here. Thank you.
Thanks, so I'm so happy to be here, and especially to see so many familiar faces from our former residents and, of course, my former mentor and teacher, Jane Edmond, who's now department chair in her own right, and to see the tremendous change and development of your program here. It's really exciting to be a part of it. So I'm going to talk to you about 5 neuro-op diagnoses you can't afford to miss.
Sorry.
It's okay. Take your time. If you have any questions, feel free to just ask me, because I think we can probably make it less formal. What is that time we're aiming for finishing?
7:30.
Okay, I'll make sure we have enough time for questions too. So my talk is subtitled, How Knowing a Little Can Harm You a Lot. And the reason is, a lot of what I'm going to show you, you probably already know, but I'm hopefully going to show you some things that will help you avoid the major errors that we see all the time in managing things that look simple, but they're not. I have no financial interest in anything I'm going to be talking to you about. I will not be discussing any off-label uses of drugs. I already shared with John that on July 20th, 1969, I was 5 years old. That was on our television. Our television was black and white. It said live from the moon. Later, I'll tell you how important that day was to me. Houston was actually the very first word spoken from the moon that day. Houston, tranquility base here, the eagle has landed. And if you've ever been to Houston, you know that that's Houston in the background. In the foreground is where I work. That's the Texas Medical Center. So if you're in Houston, please come visit me. Inside that little triangle, we see 7 million patients a year. We have 92,000 employees. We have 34,000 students, 12,000 volunteers, 4,000 residents. We have 7,000 researchers. We have 6,900 beds. And we do 350,000 surgeries every year in that little triangle. In 1978, I wanted to be a doctor. My second choice was to work for NASA. My third choice was to be a Jedi Knight. You can see me. Those are my classmates in the back. And that is Mr. Dorr. Mr. Dorr was my biology teacher. And he convinced that little guy right there to go into science. I never got to thank Mr. Dorr for that, because he died on our class field trip from a massive myocardial infarction. And I regret not telling him how important he was to that kid there. And so I'm not going to make the same mistake. I want to publicly recognize my former mentor and friend, Jane Edmond, my friend, Elliot Froman, and all the luminaries, John Shore, because what you do is so important. But what is really important is inspiring young people to do better, to do more. I think that's really what we're about as educators. In 1977, that movie came out, and that's why I wanted to be a Jedi Knight. So what I want to talk to you about are 5 things that are potentially life-threatening that come to comprehensive ophthalmologists or neurologists, to show you the rule of the pupil and how we don't really use that anymore for third nerve palsy, to show you the best imaging study for these conditions, and define for you the key and clinical differentiating feature radiographically for each of the conditions. So these I would call these A's. They're the 5 chances that an ophthalmologist, even if you're an oculoplastic surgeon or a vitreoretinal surgeon, gets to save somebody. That was for Vic. Somebody's life. So it comes to you as arteritis, apoplexy of the pituitary gland, abscess, usually mucor, fungal abscess, can be aspergillus too. Aneurysm, and that's the rule of the pupil. A pupil-involved third nerve palsy is an aneurysm of the posterior communicating artery until proven otherwise. And arterial dissection on the carotid or vertebral side. So if you just knew these 5 A's, these are the 5 chances an ophthalmologist gets to save somebody's life. This is my dad. My dad would say his definition of a good lecture was if he was making a list of things he was going to do differently on Monday. But a great lecture was if he was making a list of patients that he was going to call back on Monday because he heard something on the weekend that made a difference. And a bad lecture was if he was making a list of things he had to pick up at the store later. So I'm going to be looking at your lists. And I love this sign. It says, illiterate write for free help. Well, that kind of defeats the purpose. That should be a PSA on the radio. So it's okay to ask for help, but you have to be able to read the signs. And that's what I'm going to help you do today, is reading the signs to ask for help. You don't have to do neuro-op. You don't have to like neuro-op. You don't have to like me. But you have to RESPECT neuro-ophthalmology. Because if you don't, neuro-op disasters are ahead. So the conditions I've chosen are conditions where ophthalmology is the front line, you're seeing them first, and then we have to make a triage decision, and more importantly, the imaging study might give you a false sense of security. So those are the 3 reasons I've chosen these things. And one of the things that I hope you'll take away from this lecture is have the triage list in advance, not ad hoc. And by that I mean, if the STEM, which is what the patient says, is acute and painful plus any neuro-op sign, and it doesn't matter what that sign is, acute painful ptosis, acute painful anisocoria, acute painful diplopia, acute painful bitemporal hemianopsia. If you add acute and painful to any neuro-op sign, that's pretty much an emergency. And the second question is, how long has it been there? So whatever they say is your time clock for working it up. So if it's been there for 2 minutes, you have 2 minutes to figure out what's wrong with this person. 2 hours, same. 2 days, same. 2 weeks, okay, maybe come tomorrow. 2 months, next available. 2 years, nothing's wrong with you. 2 decades, you're faking. Or you have migraine. Those are your choices. And then how bad is the vision or the pain? If they say it's the worst headache of their life, just go to the emergency room. And if it's bad vision, light perception or no light perception vision, there are no good things that cause no light perception. If it's NLP, that's bad. The differential for NLP, bad, super, super bad. There are no good things that make you no light perception. You should not be fooling around with that. You should be saying, I know where you need to go, but not next available neuro-op. In Houston, Texas, we have 5 neuro-ops. The average wait time for a neuro-op appointment in Houston is 4 months. 4 months. I think you have 2 neuro-ops, maybe 1.5. You're probably looking at the same wait time. And the critical and important thing, whatever they're complaining about, whether it's droopy lid or diplopia or loss of vision, they need to tell you if their pupils are different sizes. So just go to the mirror right now. Because anisocoria, if you add that sign, anisocoria, to any complaint, it's already bad. Droopy lid plus anisocoria. Little pupil, that's Horner syndrome, arterial dissection. Big pupil, ptosis or diplopia. That's third nerve palsy until proven otherwise. And they're not going to know what the pupil is, so you just say the selfies. Just selfie, send it to me. Go to the mirror now, take a selfie, but not like this, like this. So these are the huge red flags that I want you to train your staff to be aware of, because when the patient calls, it's usually the staff that has to interact with them. Even if it's Sunday or your birthday or your anniversary, the standard of care does not change based on your birthday or anniversary or weekend or 5 o'clock or 4:45 on Saturday. It doesn't change. The standard of care is the same no matter what time of day it is, no matter what day it is. So here's the triage list. Acute headache in elderly, with or without vision loss, with or without jaw claudication and scalp pain. That's giant cell arteritis until proven otherwise. Acute painful ophthalmoplegia or orbital apex syndrome in a diabetic is fungal disease, mucormycosis until proven otherwise. Acute painful anisocoria with a small pupil, that's the Horner syndrome, that's a carotid or vertebral dissection. If it's the big pupil, that's the third nerve palsy, the posterior communicating artery aneurysm. Acute no light perception, well, that has no business coming to the office tomorrow. And if it's acute and bilateral, simultaneous, that's also the big red flag. Either bilateral vision loss or bilateral ophthalmoplegia. That really needs to be worked up now. I love these little ads. I'm just going to show you the pattern recognition. You just tell me when you recognize the pattern. Do you see the pattern yet? Yeah, 10-10. You see the pattern there? Look how easy it is now. So you'll never be able to look at a watch ad the same after seeing that, by the way. However, if you don't know that, how could you recognize the pattern? Like you've literally looked at watch ads 100 times, you probably never noticed the pattern. But now that you've seen the pattern, you can't actually make it go back. So that is this lecture. I'm trying to get you to see the pattern embedded in something you see every day. So the first one is the easiest one, giant cell arteritis. Every single person in this room knows that if it's an elderly patient, often female, who has new onset headache, pain when they chew their food, jaw claudication, temporal artery pain or face pain, loss of vision from AION, ischemic optic neuropathy, who has elevated SED rate and CRP, that's giant cell. Even my 16-year-old daughter, Virginia, knows that's giant cell. The thing you don't know is it's called temporal arteritis because that's where we do the biopsy. The disease is a medium to large vessel vasculitis that affects all the branches of the external carotid. And so my resident goes into the room and mashes on the person's temple, and they come out and say, and I mashed on their temple, and then they didn't jump out of the chair. That is not what we're looking for. What we're looking for is pain in the distribution of the external carotid. And that means it could be face pain, eye pain, ear pain, neck pain, tongue pain, jaw pain, any pain in the distribution of the external carotid. And the reason it's dangerous is, as soon as they say it's their neck that's hurting and they have a normal eye exam, you're going to want to say, that has nothing to do with me, go see the neck doctor. Or it's your jaw pain, that has nothing to do with me, go to the dentist. Or tongue pain, or whatever their pain is. It's your job to be a doctor first, an ophthalmologist second, and a refractive surgeon third. In that order. In that order. And if you look at this series of biopsy-proven giant cell arteritis, this is 100 cases, they're all biopsy-proven. Look at the top 4 presenting symptoms. Number 1 is headache. And as opposed to all the other headaches in the International Headache Society criteria, they can define the headache by talking to the person. There are no diagnostic features of the headache of giant cell. It's not like migraine or tension or trigeminal neuralgia, where you can just go down the checklist and you say, okay, it's cluster. There are no features of this headache. It can be mild, it can be moderate, or it could be severe. It can be throbbing, it can be non-throbbing. It can be sharp, it can be dull, it can be mild. You cannot tell. There are no diagnostic features of the headache of giant cell, and that means every headache in an elderly person is giant cell until proven otherwise. Look at number 2 on the list. Number 2 is polymyalgia rheumatica, PMR. That means proximal hip and shoulder girdle pain and morning stiffness. This is the Bird criteria for PMR. Please don't ask elderly people, do they have joint pain? If you ask an old person, do they have joint pain, they will say yes. If you ask me if I have joint pain, I will say yes. You have to ask proximal hip and shoulder girdle, stiff in the morning. That's what you need to be asking. And you can't even ask it like that. So we ask it hair, chair, stare. Do you have difficulty combing your hair? Getting out of a chair because you have hip pain, or climbing the stair? So if they say hair, chair, stare, bilateral, symmetric, morning stiffness, that is PMR, and I'll show you why that's important. Number 3 on the list is FUO, fever of unknown origin. In Houston Methodist Hospital, we're number 3 on the checklist. Chest x-ray, urinalysis, blood culture, Lee consult for FUO. In fact, in my hospital, they have an acronym, and Janie knows we joke about this. The retina docs write, impression, not the retina. That's not a diagnosis. Plan stall, S-T-A-L, stall. It means send to Andy Lee. That is, impression, not the retina, plan, stall. That is not a good plan. That is not a good diagnosis. That's not going to work. Number 4, visual symptoms without vision loss. That is amaurosis fugax or transient diplopia. So transient diplopia or transient vision loss in an elderly patient is the number 4 presenting symptom. That is completely counterintuitive. And the reason it's super important that you know this is everybody knows when the person is blind that it's giant cell. But what about 80-year-old female with normal eye exam whose chief complaint is headache? You're about to send out a giant cell. Who has PMR, but you didn't ask. Who has a fever of unknown origin. Why would she tell the eye doctor about that? She wouldn't. Or she had amaurosis fugax, transient diplopia, or transient vision loss, and you say stall, or send to peds, or go to the neurologist, or go to your PCP. These are all bad answers. And if you look at the bottom of the list, the things that we actually teach you to look for are so low. Jaw claudication, 2 people. The temporal artery pulse, the erythematous nodular artery, not applicable. So the things that we tell you to look for are not the way it comes to us. The way it comes to us is headache, PMR, FUO, and amaurosis fugax or transient diplopia with normal eye exams. This is why regular ophthalmologists, good ophthalmologists, miss giant cell. Once a person's blind, who would miss that? So look at this series from the British Journal of Rheumatology in 1997 from Font et al. All of these patients had biopsy-proven giant cell. 146 biopsy-proven giant cells. Of the cohort, 23 people, 16% of the people lost their vision, even though everybody knows about giant cell. GCA symptoms, on average, 1.3 months prior to going blind. 35% of the people, 1/3 of the cohort who went blind, had polymyalgia rheumatica, hair, chair, stare, on average 10.8 months before going blind. Somebody knows this. 65% of the people that lost their vision had premonitory symptoms, transient vision loss or transient diplopia, on average 8.5 days prior to going blind. There was a clear delay in diagnosis in 65% of the people who went blind. That's 15 people on this planet who went blind, even though every single person in this room knows about giant cell. The premonitory symptom, amaurosis fugax, does not occur in the non-arteritic form of AION. So when someone has NAION, they really can't say, I lost my vision last week and came back after 10 minutes. That's amaurosis fugax. NAION is not an embolic disease. We do not do carotid Dopplers or echoes or any of that stuff because it doesn't produce amaurosis fugax. So you need to ask every person about these symptoms. Headache, FUO, GCA symptoms, PMR, and the premonitory symptom. So some things you don't know about something you know well. You know giant cell well. You know that if you've got pallid edema, it's giant cell. You know if you're no light perception and you're an old lady, you have giant cell. You know if you have jaw claudication. Nobody misses that. That is orthopedic surgery level diagnosis. Even the orthopod knows that. The ones you don't know, posterior ischemic optic neuropathy. You look in the back of the fundus and there's nothing to see. You're going to be very tempted to say optic neuritis. Now, can an 80-year-old get optic neuritis? Yeah, but it's kind of not the top of the list, and multiple sclerosis is not at the top of the list, and you shouldn't be referring that 80-year-old to Elliot and saying, hey, I got this new MS 80-year-old. He probably is not going to like it. And I bet Elliot has seen a lot of weird MS, and I bet he still would say, you know, that doesn't sound like MS to me. And the premonitory symptom, that's the one that we miss. Transient vision loss, transient diplopia in the elderly, that is actually number 4. It is the distinctive history. The premonitory transient vision loss, that was present in the majority of the people that went blind. So which is worse, if we see a swollen nerve or we don't see a swollen nerve? It's actually worse if we don't see the swollen nerve, because at least if the nerve is swollen, that could still be non-arteritic anterior ischemic optic neuropathy. But if the disc is normal, that's PION, posterior ischemic optic neuropathy. It's posterior to lamina cribosa. We can't see anything. And what that means is whatever is doing the blindness, it's still there. And it hasn't been there for long because the nerve isn't pale. And it's retrobulbar because the nerve isn't swollen. So you have to image this, but beware, GCA. And sometimes the nerve is pale and swollen at the same time. We call that pallid edema. So it's not red, there's no hemorrhage, it's pale and swollen. And if it's pale and swollen, we call that pallid edema because the nerve is infarcted and a dead nerve can't swell very much. So if it's pallid edema, if pallid edema comes out of your pen, or it's pale and swollen, it's giant cell, until proven otherwise. And the MRI scan of the head was normal. Why? There is no MRI finding of GCA. You're just wasting valuable time here. So beware of optic neuritis in elderly patients. So the wicked good pearl, retrobulbar optic neuropathy in elderly person is usually PION, posterior ischemic optic neuropathy, and PION is usually GCA. And the nerve might not look that swollen. That will make it seem better somehow. But if it doesn't look that swollen and their vision is terrible, that's a very bad sign. So no swelling, super bad. Little swelling or pallid swelling, also super bad. So the big red flags for GCA, severe vision loss. As soon as it's LP or NLP, it is your obligation to make sure it's not GCA. If it's bilateral and simultaneous, that occurs in NAION, the non-arteritic form, but man, is it rare. You should not be making the diagnosis of bilateral, simultaneous, non-arteritic anterior ischemic optic neuropathy. That does not belong in your office. That should be in the hospital. And the transient vision loss or the transient diplopia, that does not occur in the non-arteritic form of AION. That is the wrong diagnosis. And hair chair stare. So ask about hair chair stare, PMR. It's the most under-recognized symptom of GCA. And GCA, it definitely can kill you. It's a large vessel vasculitis, which means it can go right into your aorta. And we scan patients who have chest pain or chest symptoms with GCA, and aortitis occurs in somewhere between 5 and 10% of those people. So there's 5 things I want you to remember about acute vision loss in the elderly. One's GCA. The other 4 things are GCA. This is a 75-year-old woman who was sent to me with this unexplained vision loss in her right eye from retina. Retina saw the patient and they had multifocal cotton wool patches and said it was hypertension because her blood pressure was 200 over 100. What's wrong with the diagnosis of hypertensive retinopathy here? The blood pressure in the left eye is the same blood pressure in the right. That's a big problem. You really can't have unilateral hypertensive retina. That's a weird thing. So fluorescein angiogram was performed, which showed the choroidal perfusion deficit. So you can see the cotton wool patches, and now you have choroid and retina ischemia. That's 2 circulations. Once you have 2 circulations, that's vasculitis. And once it's vasculitis in the elderly, our most common vasculitis, giant cell arteritis. So you see the massive peripapillary choroidal perfusion delay there. The black stuff, that's no perfusion. And of course, it's biopsy-proven giant cell. So in our clinic, fluorescein angiogram has gone down a lot. We do 75% less fluoresceins now in neuro-op clinic because OCT has taken over everything. But OCT cannot see perfusion and cannot see that choroid. So you still need to use the fluorescein. So if you're seeing the patient and it's a retrobulbar optic neuropathy and it's an elderly patient, instead of sending them to the MRI, you should send that person for fluorescein. If it's fluorescein and it shows choroidal perfusion deficit, that's a giant cell. Because all the other retrobulbar optic neuropathies don't cause choroidal perfusion deficit. Only vasculitis does that. And of course, the giant cell is seen there. And one of the wicked good pros I want to tell you about is the biopsy reports are very misleading. It'll say things like, no giant cell seen, no evidence for active arteritis, which is true. That's called not the orthopedic surgeon level of biopsy report. But you've got to read the body of that report, because if it says any of these, there is focal disruption of the internal elastic lamina, that is healed arteritis. There are focal areas of fibrosis. There are a few lymphocytes seen. Those are the buzzwords that it's the healed/treated arteritis, not the florid arteritis. And sometimes no giant cells are seen because no artery was in that specimen. They took a vein or a piece of connective tissue or whatever they took out. But in our hospital, what has happened is there's templates now for the pathology-admitted temporal artery, even if it isn't a temporal artery. They have to write down what you submitted. It'll say it's a temporal artery at the top. That's so strange. And then it'll say, there's no arteritis because you gave us a vein. Or a piece of connective tissue, or a piece of fluff from the OR, I don't know. So you should be aware of these uncommon presentations of GCA. Multifocal cotton wool patches, that could be hypertension, that could be GCA. PION, that's the normal appearing optic nerve. Non-embolic CRAO, so if we've got a central retinal artery occlusion with a cherry red spot and there's no embolus, you should be ordering a Sedrate and CRP on that person. Transient diplopia or transient vision loss, amaurosis fugax, and we're going to do a fluorescein on those people because if we see 2 circulations, choroid and retina, that's vasculitis. So this patient is a real patient. It was sent to me with the diagnosis of retrobulbar optic neuritis. Why? The nerve looked fine. In fact, it looks a little bit of temporal pallor. Does this 80-year-old person really have optic neuritis? I don't think so. Here's the fluorescein. Massive choroidal non-perfusion. You can see half is perfusing, and this side, the black is the perfusion, half not perfusing. No demyelinating disease can do this. MOG, NMO, none of that stuff can cause this choroidal perfusion deficit. So there's still a role for fluorescein angiogram before MRI. That's amazing in retrobulbar optic neuropathy of the elderly. So any pain, not just temporal pain, any loss of vision in an elderly person, not just AION, but PION and amaurosis fugax. And you don't have to have an elevated SED rate in CRP. That's like 20% of the people have normal labs. And you don't have to have giant cells to have giant cell arteritis. You can have the healed arteritis form. No giant cells seen, just disruption of the lamina and macrophages. Switching gears now to a different kind of patient who comes Friday, 4:45 p.m. on Christmas Eve. She's 22, she has severe headache. The tech writes 20/50 effort. The fundus is normal, the field is completely black. Why? She's in that room thinking, I can't do this test. This is a stupid test. I got the worst headache of my life. When's that lady gonna come back? She's not even pressing the button. She's like this. You cannot write unreliable Humphrey and leave that on the chart. You can write unreliable Humphrey, I did a confrontation and there's no bitemporal. That's okay. But if you write unreliable Humphrey visual field and just leave it like that, what you really wrote is, I have no visual field on this person and I don't care. And I'm going to Christmas dinner now. Because you're not trying to detect with your fingers arcuate glaucomatous scotoma. You're trying to decide yes or no, bitemporal, yes or no, homonymous. And you can do that with your fingers. You don't need that machine. And in the ER, there is no machine. In my ER, we have no Humphrey visual field. None. After hours, I have no access to my clinic. The air conditioning is turned off on the weekends to save money. We cannot even go into the visual field machine. And even if I could, who knows how to turn on and run the Humphrey? Nobody. So you have to learn how to do a confrontation field. So one of the behavior changes I'd like to ask of you is, even though we don't do confrontation field anymore because Humphrey took over, please keep your skill alive by testing people who you know have a field defect and try and find it. It'll take like 10 seconds. Oh, I know this person is a homonymous. Let me try and pretend I don't know that and find it. So that you'll keep your skill set up. Because there's no Humphrey in the ER. There's no machine in the ER, none. That means patients that come to us in the ER at Methodist, I am totally dependent on the confrontation visual field of our first-year resident. Because what's the acuity going to be in a bitemporal hemianopsia? 20/20. What's the pupil going to be? Normal. Will there be an RAPD? No. Why? It's bilateral and symmetric. What will the pressure be? Normal. What will be the motility? Normal. What will be the slit lamp exam? Normal. What will be the fundus exam? Normal. Now I'm totally dependent on the confrontation visual field of a first-year resident. In July, that means the month before, they were an intern. And a year before that, they were, having margaritas and stuff. That's who I have to depend on? Yeah. So pituitary tumor, it's super common. Maybe 1 in 500 over the age of 65. My friend Barrett Katz would say the average ophthalmologist should see 1 pituitary tumor every single year. Are you missing your quota? And apoplexy, it kills people. So it sounds like this: acute, painful, bitemporal hemianopsia. And that kills people. 8% of the people just flat out die. You kind of need your pituitary gland. It's the master gland, but the cortisol, you have to have it. So even if it's 4:45 p.m. on Friday, if you don't have the cortisol on Saturday, 4:45 p.m., you're dead. You need an emergent scan, it did help. Then they notice the blur vision. They call your office. Don't you want to know if it was acute and painful? Because they're not going to tell you about the 2-week ago headache. And your office might say this, yeah, sure, we got openings on Tuesday and Thursday of next week. That person's going to die. The reaper is here. I don't want the reaper to take my patient. 87% of the people have headache. 56% of the people, their only complaint was the vision loss. 34% of the people had the bitemporal hemianopsia. 73% of the people panhypopit. And if one of those hormones that's missing is cortisol, the clock is ticking. You can live without cortisol for a little while, but not very long. You can live without testosterone and thyroid and growth hormone. Well, some people can live without that. But cortisol, you can't live without that. And 8% of the cohort had diabetes insipidus, DI. And you'll die if you have DI. DI is the electrolyte imbalance. That's hypothalamus. You get DI, you die. So please don't do this unreliable visual field thing. The wicked good pearl is keep your skill on confrontation up a little bit. Every patient who has a bitemporal, just practice trying to pretend you didn't have that Humphrey. Because if you just leave it like that, you're writing, this person could be a brain tumor and I'm not doing a damn thing about it. And I don't want that. Okay? I don't want that. The reason we still miss pituitary apoplexy is you only know one field, the bitemporal hemianopsia. But the chiasm is the Greek letter chi. It's the crossing point. And that means it could be unilateral optic neuropathy, bilateral optic neuropathy. It could be that number 2, which is the junction of the optic nerve and chiasm, which is going to produce a field defect in one eye and a superior temporal field defect in the other eye. It could be the body of the chiasm, number 3. It could be number 4, a bilateral paracentral bitemporal from the macular crossing fiber. It could be a number 5, a homonymous hemianopsia. So, what field defect is present in a chiasmal lesion from apoplexy? Bitemporal hemianopsia is 80% of the field defects, but 20% are these other ones. Unilateral or bilateral vision loss, junctional scotoma, or homonymous hemianopsia. In other words, it can be any field defect. This patient is a different patient. He's 35, he's diabetic, they had diabetic ketoacidosis, they had a complete leftosis and an almost complete left-sided ophthalmoplegia. Why is this not a diabetic third? Ischemic, which is just going to get better and go away. Almost complete. As soon as you add that almost complete ophthalmoplegia, that is not diabetic. A diabetic is allowed one cranial neuropathy at a time. It has to be a mononeuropathy. You can have a 3, you can have a 4, you can have a 6. You cannot have a 3 and a 4. You cannot have a 3 and a 6. You cannot have a 3, a 4, and a 6. You can't have a 2, 3, a 4, and 6. That is not diabetes. But you see, when I ask my resident, did this person have a 4th nerve palsy? They're like, no, it's a 3rd. I know it's a 3rd, you dummy. No, did they have a 4th and a 3rd? They're like, how do you test a 4th when they have a 3rd? So when the eye is out like this, down and out, what we're looking for in a 4th nerve palsy is the superior oblique. The superior oblique's primary action is intorsion. So when they look down, they better intort. What if they don't intort? That's not diabetes anymore. That's a 3 and a 4. And you're not allowed to have a 3 and a 4. They're numbered for a reason. And that means you have to check number 2, number 3, number 4, number 5, number 6, and number 7. You don't have to check those other ones. And close your ears, Elliot. I just told them not to do the rest. But those you have to do, 3 through 7. Because the life-threatening diagnosis here is mucormycosis. So diabetic ketoacidosis, mucor. And what we're looking for is enhancement in the sinus. So there's the sphenoid sinus. The adjacent cavernous sinus is enlarged and asymmetrically enhancing. But if you don't tell them that you're worried about fungus, the reading of this scan will come back very weird. Radiology will say there's asymmetric enhancement and enlargement in the cavernous sinus, consistent with the ophthalmoplegia history. The differential diagnosis, and now this is where they're going to try and mess with you. Meningioma, infiltrative neoplasm, granulomatous inflammatory disease, including the Tolosa-Hunt syndrome. What if my resident sees that Tolosa-Hunt thing there with a painful ophthalmoplegia? What's the treatment for this granulomatous inflammatory disease in the cavernous sinus? Steroid. What will happen to this person who actually has fungus if you give steroid? You'll get fungus among us. And the book says diabetic ketoacidosis, DKA, and that's true. But any acute painful ophthalmoplegia or orbital apex that comes to you as a consult from the hospital with any of these, hey, can you come and see this diabetic in the hospital? They're in DKA. Okay, that's Mucor. ICU, cancer patient, immunosuppressed, corticosteroids, renal dialysis, chronic antibiotics, survivor of solid organ transplant. All of those are fungus until proven otherwise. It's your job to make sure it's not fungus before you tell the person it's small vessel ischemia and it's going to get better. So now you've seen it two ways. The sella turcica, pituitary apoplexy, can jump right up and hit your chiasm. It can go right in your cavernous sinus too. Or the sphenoid sinus or the ethmoid sinus can jump right into the cavernous sinus, and that's fungus. So this is one of my patients from the University of Iowa. Our resident was called to see this 76-year-old woman who had acute myelogenous leukemia. She was on induction chemo day 13. They called because she had a little bit of puffy eye. That was the consult, puffy eye. She had periorbital swelling and erythema. The resident went up and they have a puffy eye. They have mild erythema and edema, chemosis. A CAT scan had already been performed which showed pansinusitis and some non-specific fat stranding. Is this really orbital inflammatory pseudotumor? Is this Tolosa-Hunt syndrome? Should you be giving immunodiagnoses to people with no immune system? Don't give people who are immunosuppressed autoimmune, inflammatory, and idiopathic diagnoses. There is nothing idiopathic about this case. Do not write idiopathic if the person is pathic. They are sick. Do not do that. So, for example, if it's optic neuritis, it could be idiopathic, but they get stage 4 lung cancer. It's the cancer. So we went up to look their nose. ENT saw pale necrotic tissue. They biopsied it and they said it didn't really bleed that much. That's a very bad sign. It was mucor. Angioinvasive mucor. You see all the hyphae there. The whole thing was nothing but hyphae. The pansinusitis was nothing but hyphae. The whole thing was hyphae. And it's angioinvasive. It goes right into the carotid. It'll kill you. In the book, it says to look out for this black eschar thing. Do not wait for this black eschar. Oh, it's the black eschar again. No. By the time the black thing comes, that's game over. Necrosis, game over. Most of our fungus is aspergillus in our hospital. And the MRI scan of the head was normal. Why? Number one, it's an MR of the head, and the disease was in the sinus and the orbit. Number two, they didn't give any contrast because the person's diabetic and they have diabetic kidney disease and they don't want to give the gadolinium. Number three, fungus is hyphae, little dried out hyphal elements, no water. MRI requires proton requires water. Fungal hyphae, they're like dark. You can't see them. And if you don't do fat suppression, you can't see anything. And it's super dangerous because if it presents as an optic neuropathy, you're going to want to give steroids. Acute, unilateral, loss of vision, RAPD, normal fundus. Doctor sees nothing, patient sees nothing, MRI scan, negative. Oh, let's give this person some steroids. Nobody should go blind without steroids. What? Tolosa-Hunt. I hate that diagnosis. Most of the Tolosa-Hunt that I see is Tolosa-Not. And the MRI scan of the head was normal. Why? You can't see the fungus. So the distinctive radiographic sign is whatever you're seeing, in this case optic neuritis on the left, the adjacent underlying sinus is also enhancing. So if the sinus is enhancing next to the optic nerve, or the sinus is enhancing next to the orbital apex, or the sinus is enhancing next to the cavernous sinus, that's the tip-off that it's fungus. And the reason it's dangerous is if you don't tell the radiologist you're looking for fungus, they just bury that in the report body. It'll say there's incidental note of pansinusitis. The sphenoid sinus has mucosal thickening and enhancement. And also we see the left optic nerve is enhancing. What they should say is the left optic nerve is enhancing. The adjacent underlying sphenoid sinus is also enhancing. Given the clinical history of diabetes and diabetic ketoacidosis, it's highly likely that your patient has mucormycosis. They don't say any of that. If you don't give the contrast, you won't see the contrast enhancement. They should say, your lack of contrast makes this a completely worthless study for looking for the thing you're looking for. Instead, they just say this, non-contrast MR head shows no acute intracranial process. That's what it'll say. So whatever they see next to whatever you see is badness. That's what you have to look for. And this was aspergillosis. So yes, the optic nerve is enhancing in the orbital apex, but look at the adjacent ethmoid sinus. It's actually enhancing more. So whatever is in the optic nerve is also in that ethmoid. Don't let them read it like that. And if you don't give the contrast, that's North Korea at night. It really is North Korea at night. It looks like South Korea is an island. Do you see how dark North Korea is at night? Because they can't turn the lights on. They can't power their country. So it literally looks like the South Korean peninsula is an island floating off the coast of Asia. Because at night, you can't see North Korea, except Kim Jong-un's house. So you need to have fat suppression. This is fat sat. On T1, the fat is very bright. It's too bright. See the fat in the orbit? Too bright. I don't want that fat. This is no fat suppression. You see how bright the fat is. If you give the contrast, you can see the contrast in the nose and in the cavernous sinus here. Can you tell if that nerve is enhancing? Can you tell if there's an enhancing mass in there? Why not? White stuff on white stuff is white stuff. This MRI scan will be read as normal. It should say, you did not order the fat suppression here, and how the hell are you going to expect me to see the contrast enhancement when white stuff is on white stuff? But it doesn't say that. It just says, MRI with and without contrast shows no acute intracranial process. And you're going to tell the patient, good news, I have no idea why you have this orbital apex syndrome. I'm going to let you go. But maybe it's optic neuritis, and just in case, I'm going to give you a little bit of steroid. Polar bear in a snowstorm. If you don't suppress that fat, you cannot see the enhancement. And fungus, it's dark. That MRI says there's nothing in there. The CAT scan on the same day says that sinus is completely full of hyphae. CAT scan is the imaging study of choice for sinusitis. CAT scan is the imaging study for mucor and aspergillosis, not MRI. CAT scan of the orbit and sinuses, not MRI of the head without contrast. You're just asking for a negative study. That is fungus. It's full of fungus. This is a 60-year-old diabetic man who has an adduction, elevation, depression deficit. The pupil was already dilated and then sent to me as an ischemic third. Who in their right mind would do this? Retina. They dilated the person without looking at it. You have my permission to not dilate a third nerve palsy. We can find their little ora serrata pearl next time. We can look at their diabetic retinopathy next time. We don't have to dilate this person. What is the point of your dilating a third nerve palsy? There's no point to that. None. You have my permission not to dilate this person. Because either this is a diabetic ischemic third nerve palsy that's just going to go away in 6 weeks with no treatment, or it is the life-threatening posterior communicating artery aneurysm that's going to rupture and kill this person in the next 29 days. Or maybe the next 29 minutes. There's no way for you to know that. So you tell the techs, look, if you have to lift up a completely ptotic lid, or the patient's chief complaint is diplopia, I know this is retina clinic, but that ain't retina. Please don't let me dilate that person. Let me look at their pupil, and if it really is ptosis, and it really is anisocoria, and it really is diplopia, we're going to go to the hospital. Because if it's a pupil-involved third nerve palsy, the life-threatening diagnosis is aneurysm. And that's the rule of the pupil. A pupil-involved third is an aneurysm of the PCOM until proven otherwise. Now, there's probably 50 people in this room. One of you is harboring an intracranial aneurysm. You just don't know it. I'll just say it again. One of you has it. You just don't know. So look to your right. Look to your left. If you can't figure out who it is, it's you. It's you. And the MRI scan of the head was normal. Why? You need an A to find an A. The A we're looking for, aneurysm. The A to find it, angiogram. There is no A in MRI. You have to have an A. CTA, MRA, DSA, some kind of A. So I just told you the rule of the pupil. We don't follow this anymore. We image all third nerve palsies now with the A. CT, A, MRA, followed by MRI. It is what we are doing now. Why? Partial palsies, partial pupil. The pupil is slightly larger. They're diabetic and their pupil doesn't react. We used to have all these debates about whether we should do that. But non-invasive imaging has made that all go away. The reason we had all those fights about who should we do an angiogram on is because we only had catheter angiogram. Now we have these kinds of angiograms. There's no reason not to do it. In the old days, we were worried about stroking people from doing a catheter angiogram. We don't have to worry about that anymore. So the rule of the pupil, you should know it, but in the real world, just scan them. There's no I in team, and there's no A in MRI. You have to have an A. And this is what we're looking for, that aneurysm right there, or that jalapeno pepper right there. If this thing ruptures, half the people die at the scene, never make it to the hospital. They just die. Of the people who make it to the hospitals and survive the subarachnoid hemorrhage, half of those people are going to be permanently neurologically impaired for the rest of their life. If, however, we diagnose the aneurysm prior to the rupture, prior to the subarachnoid hemorrhage, coil or clip, hospital day 3, go home. Have a nice life. You saved them. Don't wait until the worst headache of my life. Because once we put the coil in there, it's a cure. Literally, a cure. So, our imaging strategy now, non-contrast CT followed by contrast CTA in the emergency room. The non-contrast CT is to look for subarachnoid hemorrhage. If we see the subarachnoid hemorrhage, you're done. Just go home. You can read on Epic tomorrow what happened to them. If the CTA shows aneurysm, you're done. Neurosurgery. If it's negative, you still have to do an MRI because there are non-aneurysmal causes like cavernous sinus tumor that will be missed on a CT-CTA. And if you still think it's an aneurysm, catheter angiogram, this is not your call. Your call is to the person who makes that call, and that person is not you. Your call is to the person who makes the call, and that person is in the hospital, not in the Orbit clinic, not in your outpatient center, no. My name is no. My sign is no. My number is no. You have to call someone to make this call, not you, not you. Because if you miss this, people die. The average ophthalmologist sees this once in their career. And you've got to check for 4, because 3 is next to 4. How do we check for 4? So we're looking at that blood vessel there, and we're going to look for the intorsion. Because if you don't do this, you go into the room, the eyes turned out and down like this. You're so excited to see the 3rd. You're like, oh, aneurysm, angiograms, oh, hospital. But what if the 4 is involved? Then it's not a PCOM aneurysm anymore now, is it? Because 3 and 4 don't live next to the PCOM. That places the lesion in the cavernous sinus or the orbit. If you let it go to the hospital without telling them it's a 4, CT, CTA, MRI, MRA, all normal. Then they do catheter angiogram, no aneurysm. Hey, good news, you have no aneurysm. We're going to discharge you now because we didn't look in the orbital apex or the superior orbital fissure or the cavernous sinus where your lesion actually is because we didn't check 4, because we got so excited to see the 3rd. And you need to check 2. They're numbered for a reason. 2, live 3, live next to 4. If I ask my resident, hey, did the 3rd nerve palsy, the pupil-involved 3rd, have an RAPD? They say, what do you mean? The pupil was fixed and dilated. Not that pupil, you dummy. You only need 1 working pupil. You have to have 2 eyes, but you only need 1 working pupil to test for an RAPD. So as long as we have 2 eyes and at least 1 working pupil, we can test for an RAPD. So the pupil is fixed and dilated on the 3rd nerve palsy side. We can still detect an RAPD in the 3rd nerve palsy eye by swinging the light from the left to the right. It doesn't constrict, but we're going to look at the left pupil. Because if there's an RAPD on the right, the left pupil will dilate when we swing the light from the left to the right. That we call a reverse RAPD, but there's nothing reverse about it. It's there every single time. You just never looked over there. You never looked over there. But when you swing the light from the left to the right and you have a right RAPD, both pupils dilate. Not just the right one, both pupils dilate. And what if it is a 2 and a 3? Now the lesion is in the orbital apex. Now it is not an aneurysm. Now you don't need a CTA and an MRA and a DSA. What you need is a CT of the sinuses and orbit, because this diabetic patient doesn't have an aneurysm. They have the mucor thing again. Don't let the mucor leave. I love this sign. It says, touching wires causes instant death. There's also a $200 fine. So now let me tell you about the $200 fine. This is Neuro-op and OMIC, the Ophthalmic Mutual Insurance Company. You can see most of our lawsuits are cataract, LASIK, retinal detachments, Neuro-op, teeny tiny. See how small we are? These are the payouts. Neuro-op is the loss leader for OMIC. Our payouts. You could literally pay 50 cornea cases and still not get a neuro-op case. And look what's right next door. And if it's pediatric neuro-op, you can just take that bar and put it right on top of it. So, want to end up with this Horner syndrome thing. In the book, it says to put these drops, cocaine, hydroxyamphetamine, localize, just image the whole axis. Hypothalamus all the way down to C8, T2 in the chest. So look, the person has an anisocoria after a car accident. What are we worried about? Dissection. It's a life-threatening thing. 24% of the people are going to stroke within 24 hours. Another 20% in the next week, another 15% in the next month. They're going to die or be paralyzed. You got to know what this is. So the left Horner syndrome and pain usually means cavernous sinus, but because it's the visceral afferent goes right to where the somatic afferent goes, the pain can be felt in your eye, even though the problem is in your neck. And the MRI scan of the head was normal. Why? The dissections are extracranial. They occur in your neck. Both the vertebral dissection and the carotid dissection are in the neck. The MRI of the head is a totally false sense of security here. And yeah, you're going to ask about the trauma. You're going to look for a branch retinal artery occlusion. And the book, it says the drops. Just don't waste time on the drops. Just image them. And that's what we're looking for, a crescent sign of hyperintense signal intensity surrounding that carotid flow void. But it's in their neck, not in their head. No flow on the carotid on that right side. And what I mean by that visceral afferent is, it's just like your heart. You can have a heart attack, but you feel the pain radiating down your left arm. There's actually nothing wrong with your arm. But the vagus, the visceral afferent, is sending the pain signal so that you feel it in the somatic afferent. So the general visceral afferent is sending the pain signal, but you're feeling it in the general somatic afferent. And for an ophthalmologist, what that means is we have our own version of this. They feel the pain in their eye, but there's nothing wrong with their eye. The problem is they have a dissection in their neck. You're going to think the problem is up here. So they have a Horner's and an eye pain, and you're going to be really tempted just to image the head. But the dissection is here. They just feel the pain in their eye. That's a referred pain, just like heart attack. And you see how many people leave the ER and they have a heart attack, but they were given the wrong diagnosis because their pain was in their arm or in their back or wherever the referred pain was. So this referred pain, you need to know about it. The general visceral afferent on the vagus supplies the carotid. It sends the signal right to the eye. So you think the problem is eye, but it's not. It's not. All right, last case. 70-year-old woman. She's a judge. Her name is Judy. She had amaurosis fugax. She had a normal eye exam. She was told it was ocular migraine. I love this sign. It says, "Is there life after death? Trespass here. Find out." MRI scan of the head was normal. Why? The problem's in her neck. So the carotid occlusive disease, you cannot see that on an MRI of the head. Okay? Amaurosis fugax, admitted to the hospital. And it doesn't have to be a carotid dissection or carotid disease. It could be vertebral. It can present as a homonymous hemianopsia. So now you've seen it both ways. It can cause one eye loss or two eye loss. The homonymous hemianopsia, transient, or the monocular vision loss. Both are amaurosis fugax. One's in the posterior circulation, vert. The other's in the anterior circulation, carotid. Or it can present as bilateral ophthalmoplegia because the vert becomes the basilar, and the basilar has perforators into the brainstem. And the initial MR might be normal because it was done too fast. And we need to know if this is a vert dissection. And it looks exactly like the carotid dissection, a crescent sign of hyperintense signal surrounding the flow void of the vertebral. So in summary, you should now know about these 5 potentially life-threatening diagnoses: arteritis, apoplexy, abscess, arterial dissection, and the rule of the pupil for the aneurysm. You should know now that we don't really use that rule of the pupil anymore. Just image everybody. You should know that MRI of the head is completely false sense of security, because MRI of the head in giant cell shows nothing. MRI of the head of aneurysm has no A to find the A. MRI of the head is missing the dissection, which is in the neck. MRI of the fungus is black, and the no fat sat, you can't see anything, and you might give that person steroids. That MRI has no brain. You must use your own. A negative brain MRI in no way replaces a neuro-op. No way. So, my dad's list. It should look like this: headache, elderly person, vision loss, arteritis, apex syndrome, or ophthalmoplegia in diabetic. Check that 4, check that 2, Mucor. Acute painful anoscoria, big pupil, rule of the pupil aneurysm, small pupil Horner syndrome, it's dissection, bitemporal hemianopsia, apoplexy, painful homonymous hemianopsia. That is the dissection in the vert. Bottom line, it's your job. Cataract, 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 what was that, third nerve? Cataract, cataract, glaucoma. No, scrape that sucker off. It's your job. And I just want to end, and if I have a second, with this philosophical question, which is, the reason you're here with me is you believe something. And what you believe is that you make a difference. I know this because you wrote it in your personal statement. I know this because I just told the medical students to do the same thing. Write it, live it, believe it. Be the doctor your mother already thinks you are. I care about feedback. I care more about you and your patients. So the next time you see me in Hawaii or at that banyan tree meeting or at the academy, tell me you learned something. Tell me you made a difference. I collect these little anecdotes where people tell me, I heard something at your lecture, I saved somebody. I collect them like baseball cards. They're really, really important to me. And if you want to watch a really great lecture on video, watch this guy's lecture. It's called Randy Pausch's last lecture. The reason it was his last lecture is he had uncurable pancreatic cancer. He was a teacher like me, and he decided to make a lecture for posterity. If you watch this lecture, it will change your perspective on education. This is what he said: it's a thrill to fulfill your own childhood dreams, but as you get older, you may find that enabling the dreams of others is even more fun. That is the stage I am at now. I think it is the stage that John is at and Janie is at. They are here to serve you. They are not here to serve themselves anymore. We have already climbed that mountain. We're on mountain number 2. Mountain number 1 is over. It's not about me anymore. It's about you. So I want to end with this patient. She's 73 years old. I saw her in 1997. I diagnosed her with paraneoplastic optic neuropathy. We found the small cell carcinoma with a chest x-ray. It was resected, chemo, and she was cured. She came back to see me in 2010. No chief complaint. What she said was, I just wanted to say thank you. I'm still here. I wrote that up in J&O in 1997. So she comes back. You don't remember me, do you, Dr. Lee? Sure, maybe. I had lung cancer. You found it through my eye. Really? You wrote it up in a journal. I remember. Yeah. How are you doing? I just wanted to tell you I'm still alive. It's been 14 years. So what do you do with that? Wrote it up. I got two papers out of one patient. She is the longest known survivor of paraneoplastic optic neuropathy, not just in Houston, not just in Texas. In the history of this planet, nobody has lived as long as she has. And last year, my wife, Hillary Bieber, took her cataract out. That was 1997. Your dream is my dream. Making a difference is what I wrote in my personal statement. It's also what you wrote. Enabling your dream is my dream. That's why I agreed to come here today. I have to go fly to Hawaii tomorrow.
Damn.
But today I am with you. And I thank you for your time and attention.